To lab diagnosis of URTI, specimen collection and transport, throat swab or oropharyngeal swab containing fibrous exudate is the ideal specimen for pharyngitis. It should be collected by vigorous rubbing of sterile swab over the posterior pharynx and both the tonsillar pillars. Two swabs may be collected, one for DX smear and other for culture. Specimen other than throat swab include in suspected diphtheria, portion of pseudomembrane may be obtained. Nasopharyngeal swab is preferred for Bordetella pertussis or virus like influenza or coronavirus. It is collected by inserting the flexible swab through nose into posterior nasopharynx and then rotating for 5 seconds. Types of swabs, Dacron or rayon swabs are suitable for collecting most URT microorganisms. Flocked swabs are preferable. Cotton swab can be used for Streptococcus pyogenes but not suitable for virus like Bordetella pertussis. Transport for isolation of most URT bacterial pathogens. Swab should be processed within 4 hours. However, for molecular diagnosis bacteria or virus, specimen can be stored at 4 degrees Celsius and can be processed late. Special transport media such as amines or Stewart's media, charcoal based, may be preferred for Bordetella pertussis. Diagnostic methods. Gram staining is not useful for most of the URTI. Albert stain may be preferred when diphtheria is suspected. If oral thrush or Vincent's angina is suspected, gram staining can be performed. Culture specimen may be inoculated onto blood agar and chocolate agar. Additional media may be used such as potassium tellurite agar for Clostridium diphtheria. Regan low media for Bordetella pertussis. Molecular diagnosis. This is the gold standard method for the detection of respiratory virus such as influenza or coronavirus and others. Real-time PCR is available for targeting genes specific for SARS-CoV-2, influenza A, H1N1 and other respiratory virus. Biofire film array or automated multiplex PCR is commercially available. Its respiratory panel can simultaneously detect 22 most common pathogens involved in URTI, 17 virus and 3 bacteria. In a turnaround time of 1 hour, it has an overall sensitivity and specificity of 95% and 99% respectively. Antigen detection test may be useful for detection of certain URT pathogens. Rapid antigen detection test for detection of group A carbohydrate antigen of Streptococcus pyogenes in throat swabs. Direct fluorescent antibody DFA staining for detection of Bordetella pertussis in nasopharyngeal secretions. Recently, a rapid chromatographic immunoassay has been developed for detection of SARS-CoV-2 from nasopharyngeal swabs. Antibody detection in serum is less useful for URT pathogens. They only provide retrospective evidence of infection and are used for seroepidemiological purposes. Now coming on to oral cavity infections. Infections of the oral mucosa, stomatitis. Stomatitis is an inflammation of the mucous membrane of the oral cavity. It is caused by herpes simplex virus HSV, characterized by multiple painful tiny vesicular lesions on the oral mucosa and in the oropharynx. Recurrences are common but the lesions are less severe. HSV infection of the oral cavity is more common in immunosuppressed patients. Oral thrush or oral candidiasis. Candida species can also invade the oral mucosa, especially in immunosuppressed patients, example HIV. It is characterized by whitish patches of exudate, the area of inflammation, which are observed on buccal mucosa. It may extend to the tongue, oropharynx or esophagus, especially in HIV infected individuals. Dental and periodontal infections. Dental infections include infection of the tooth or the supporting periodontal structure. Dental infection more commonly occur when the bacteria invade the pulp and spread the surrounding tissues. This can occur due to trauma, dental procedures or dental caries, cavity formation in the tooth due to destruction of its mineralized tissues caused by virulent streptococci. Periodontal infection mostly results from poor or ineffective dental hygiene, leading to plaque formation and subsequent inflammation of tissues around the teeth. Etiologic agents. Common organisms implicated in dental infections are primarily the anaerobic bacteria and virulent streptococci found in the oral cavity. Anaerobic bacteria, they account for up to 50% of the dental infections, which include anaerobic cocci, Peptostreptococcus and Veillonella, anaerobic gram-negative bacilli such as Prevotella, porphyromonas such as Bacteroides fragilis and Fusobacterium, and virulent streptococci like Streptococcus anginosus group are usually found in 20 to 30% of the dental infections. Common dental infections. Common dental and periodontal infections include root canal infections with or without periapical abscess. Dental periapical abscess is the more common in children, occurs secondary to dental caries. Dental caries erode the protective layers of the tooth, that is enamel, which allow bacteria to invade the pulp, producing pulpitis. Pulpitis can progress to necrosis with bacterial invasion of the alveolar bone, causing an abscess. Periodontal abscess, it involves the supporting structures of the teeth, periodontal ligaments, alveolar bone. This is the most common dental abscess in adults but may also occur in children. Spread dental infections have a potential of spreading to the surrounding tissues such as gingivitis, gums, orofacial infections, osteomyelitis of the jaw, perimandibular space infections, etc. Now, the salivary gland infection, parotitis, inflammation of the parotid gland can be caused by both bacteria and viruses. Mumps is traditionally the most common virus to cause parotitis, although the cases are significantly reduced in size. The advent of childhood vaccination. Uh, Reduced in size since the advent of childhood vaccination. Influenza virus and enterovirus may also cause parotitis. Acute suppurative parotitis is seen among severely sick, malnourished, or elderly patients, characterized by painful, tender swelling of the parotid gland. Purulent drainage may be evident at the opening of the duct of the gland in the mouth. Staph aureus is the major pathogen, but occasionally Enterobacteriaceae, other gram-negative bacilli, and oral anaerobes may also be implicated. Now, a chronic bacterial parotitis has been described involving Staphylococcus aureus. Now, Vincent's angina, it's an acute necrotizing ulcerative gingivitis, also called as trench mouth or Vincent stomatitis. Clinical manifestation, it presents as gingivitis with sudden onset of painful or bleeding gums, foul breath, and a bad taste. The gingival mucosa becomes ulcerated and may be covered by grey pseudomembrane, resembling diphtheria but peels off easily. Patients may become systemically ill. Mortality is high if not treated. Agents, organisms such as Prevotella, Borrelia vincenti, and Fusobacterium species have been implicated. They are normal flora in the mouth. Diagnosis, demonstration of spirochetes and fusiform bacilli in the stained smear of exudate from the lesion remains the mainstay of diagnosis. Treatment consists of debridement and antibiotics, metronidazole plus penicillin. Now, the lower respiratory tract infections, LRTI, include bronchitis, bronchiolitis, whooping cough, pneumonia, tuberculosis, fungal and parasitic lung disease, and lung abscess, pleural effusion, and empyema. Now, bronchitis. Acute bronchitis is defined as self-limited inflammation of the bronchial tree due to infections. Most infections occur during the winter. Etiology, most commonly caused by respiratory virus, 20 to 50%, such as RSV, influenza, and coronavirus. Bacterial causes include Mycoplasma pneumoniae 5%, Chlamydophila pneumoniae 5%, and Bordetella pertussis. Manifestation, acute bronchitis presents with persisting cough, variable fever, and sputum production. Sputum is often clear at the onset but may become pleurent as the illness persists. Chronic bronchitis is clinically defined as a cough with expectoration for at least 3 months or years during a period of 2 consecutive years. It usually affects adults. In contrast to acute bronchitis, which typically has an infectious etiology, in chronic bronchitis, there occurs a chronic irritation of bronchial mucosa due to the factors such as cigarette smoking. Smokers with underlying COPD, chronic obstructive pulmonary disease, may suffer from acute bacterial exacerbation of chronic bronchitis, characterized by increased dyspnea, increased sputum viscosity or purulence, and increased sputum volume. Bronchitis. Acute bronchitis antibiotics are not effective and are not indicated except when bacterial cause is suspected. Example, pertussis. Symptomatic treatment is the mainstay of the treatment, such as antitussive plus inhaled bronchodilators can be given. For chronic bronchitis, antibiotic therapy is recommended only if presented with acute bacterial exacerbations. Amoxicillin or azithromycin is given for mild cases, whereas for hospitalized patients with severe disease, anti-pseudomonas coverage is also given, such as levofloxacin, cefepime, or piperacillin tazobactam. Bronchiolitis. Bronchiolitis, inflammation of the bronchioles, is almost always caused by respiratory viruses. It usually affects infants and younger children and most commonly during winter. Agent, respiratory syncytial virus RSV is the most important etiology. Others include influenza virus, human metapneumovirus, parainfluenza virus, adenovirus, rhinovirus, and coronavirus. Manifestation characterized by respiratory distress with expiratory wheeze, tachypnea, nasal flaring, retraction, and irritability. Treatment, bronchiolitis. Mainstay of therapy is symptomatic management such as hydration, oxygen supplement, and suctioning to clear the airway. Antibiotics should not be used for bronchiolitis unless there is clear evidence of a secondary bacterial infection. Whooping cough or pertussis is a respiratory disease caused by gram-negative Bordetella pertussis, clinically characterized by paroxysmal cough. Each paroxysm consists of bursts of 5 to 10 repetitive violent spasmodic coughs, often within a single expiration, which ends with an audible sound of whoop. Pneumonia. Pneumonia refers to the infection of the pulmonary parenchyma, which can be classified into community-acquired, patients-acquired infection in the community, and hospital-acquired, in which patients acquire infection in the healthcare facility. Community acquired pneumonia CAP. Etiology of CAP is different from that of HAP, which vary depending upon the comorbidities. Streptococcus pneumoniae followed by Mycoplasma pneumoniae is the most common agents of CAP. Others include Haemophilus influenzae, Chlamydophila pneumonia, and viral pneumonia. Pathogenesis of CAP depends upon two factors: microbial pathogens that gain access to the lungs and host response to those pathogens. Microbial pathogens gain access to the lungs. Microbial gain access to the lower respiratory tract in several ways. The aspiration from the oropharynx most common. It occurs frequently during sleep, especially in elderly or when consciousness is lowered. Inhalation of the pathogens through infected droplets via hematogenous spread, example from tricuspid endocarditis, which is rare, and contiguous extension from an infected pleural or mediastinal space, which is rare. Microorganisms escape the defense mechanism of the host respiratory tract. Uh, Example, mucociliary clearance. Host immune response. Once the microorganism reach the lungs, they are engulfed by the resident alveolar macrophages and subsequently are either killed or eliminated by mucociliary escalator or through the lymphatics. Only when the capacity of the alveolar macrophages to ingest or kill the microorganism exceeds, clinical pneumonia manifestation occurs. In that situation, the inflammatory response is initiated by the alveolar macrophages rather than preventing the proliferation of microorganisms, triggers the clinical syndrome of pneumonia. They release a cascade of cytokines which act as inflammatory mediators causing host tissue damage, cytokine storm. Interleukin 1 and tumor necrosis factor induce fever. Chemokines such as IL-8 and granulocyte colony stimulating factor stimulate the release of neutrophils. Subsequently, the inflammatory mediators create an alveolar capillary leak as seen in the acute respiratory distress syndrome ARDS. The capillary leak results in a radiographic infiltrate. Rails are detectable on auscultation and hypoxemia results from alveolar filling. Now, let us see the agents of community-acquired and healthcare-acquired pneumonia. CAP. Bacterial pneumonia includes Streptococcus pneumoniae, Mycoplasma pneumoniae, Haemophilus influenzae, and Chlamydophila pneumoniae. Viral pneumonia includes influenza coronavirus, including COVID-19, respiratory syncytial virus, parainfluenza, and adenovirus. About HAP, multidrug resistant MDR pathogens found in the hospital environment are Pseudomonas acinetobacter, E. coli, Klebsiella pneumoniae, and MRSA methicillin resistant Staph aureus. Note, the distinction between CAP and HAP is vague. Many individuals presenting to the outpatient department with pneumonia have been found to be infected with MDR pathogens. Factors responsible for the phenomena include the widespread use of antibiotics in the community, earlier discharge of the patient from hospitals to their homes, increased use of outpatient IV antibiotic therapy. VAP, ventilator-associated pneumonia accounts for majority of HAP. Now some comorbidities of community-acquired pneumonia. Factors: alcoholism, radiological agents are Pneumococcus anaerobes coliforms. COPD and smoking agents are Haemophilus influenzae, Moraxella catarrhalis, and Pneumococcus and Legionella. Post-CV aspiration agents are oral flora and Pneumococcus. Post-obstruction of bronchi agents are Pneumococcus and anaerobes. Uh, Post-influenza agents are Pneumococcus and Staph aureus. Neutropenia and low immunity agents are Pseudomonas aeruginosa. Injection drug use agents are Staphylococcus aureus. Structural lung disease example bronchiectasis agents are Pseudomonas aeruginosa, Burkholderia, Cepacia, and Staph aureus. And about decreased consciousness agents are oral anaerobes, gram-negative enteric bacteria. CVA means cerebrovascular accident and COPD means chronic obstructive pulmonary disease. Now coming on to HAP, hospital-acquired infections. Hospital patients are at risk of developing pneumonia, majority of which are attributed to the presence of ventilator. The normal respiratory flora of hospitalized patient gets quickly replaced by multi-drug resistant gram-negative organisms present in the hospital environment such as Pseudomonas, Acinetobacter, etc. Endotracheal intubation damages the respiratory epithelium and thus helps oropharyngeal bacteria to gain access directly into the lower respiratory tract. Ventilator-associated pneumonia is a major healthcare associated infection. Clinical manifestations of pneumonia. Based on the area of lungs involved and the type of cough-produced pneumonia can be traditionally grouped into typical and atypical pneumonia. Lobar or typical pneumonia refers to the infection of lung parenchyma alveoli. It is characterized by consolidation radiologically, which gives a dull note on percussion and productive cough with prudent sputum. It is mostly caused by pyogenic organisms such as pneumococcus, most common agent, Haemophilus influenzae, and Staphylococcus aureus. Gram-negative bacilli such as Klebsiella pneumoniae. Interstitial or atypical pneumonia refers to the infection of the interstitial spaces of lungs. Cough is characteristically non-productive. Radiologically, it presents as a patchy reticulonodular opacities, chest X-ray, and ground glass opacity CT scan. It is mostly caused by organisms such as Chlamydophila pneumoniae, Mycoplasma pneumoniae, viral agents causing pneumonia, fungal agents causing pneumonia, and Legionella species. This is a CT scan depicting lobar pneumonia with consolidation of the both lower lobes. Okay. This is a CT scan for COVID patient showing ground glass opacity seen in both lungs, predominantly subpleural in distribution. Ground glass opacity is a feature of interstitial pneumonia. However, there is considerable overlapping. The typical agents can be atypical in presentation and vice versa. Clinical features which may be found in both types of pneumonia include fever with chills and or sweats, tachycardia, increased respiratory rate like tachypnea with increased use of accessory muscles for respiration. Dyspnea, shortness of breath. If pleura is involved, the patient may experience pleuritic chest pain. Gastrointestinal symptoms may be seen up to 20% of the patients such as nausea, vomiting and or diarrhea. Other symptoms may include fatigue, headache, myalgia and arthralgia. Severely ill patients may develop septic shock and multi-organ failure. Community-acquired pneumonia. Emp- Empiric regime differs for patient, inpatient and outpatient. Hospitalization in CAP is determined based on CURB 65 scoring system. The prognosis of CAP can be predicted by a scoring system called CURB 65. CURB 65 score is more than 1. Prognosis is poor and requires hospitalization. CAP hospitalized if CURB 65 score more than 1. IV ceftriaxone plus azithromycin or IV levofloxacin not recommended for severe CAP. Add vancomycin if CA-MRSA is suspected. Add piperacillin tazobactam if Pseudomonas is suspected. CAP outpatient if CURB 65 score less than equal to 1. For outpatient, empirical regime is dependent on the presence of comorbidities. If no comorbidity present, oral amoxicillin or doxycycline is given. Okay. Now, uh, if comorbidity is present, example chronic heart, lung, liver or renal disease, diabetes, alcohol use disorder, neoplastic disease, acelinemia, oral amoxicillin, calvinate plus azithromycin or oral levofloxacin can be given. Duration of treatment is 5 to 7 days, guided by clinical stability such as afebrile more than 48 hours, normalization of vital sign. This is a prediction of prognosis in community acquired pneumonia CAP. C is for confusion of new onset, 1 point. U is for blood urea nitrogen more than 19 mg per dl, 1 point. R is for respiratory rate more than 30 minutes, 1 point. B is for BP less than 90 upon 60, 1 point. And 65, age is more than equal to 65 years, 1 point. This is together called CURB 65. Higher the score, greater is the mortality. If score is less than equal to 1, outpatient therapy is indicated. If score is more than 1, patient should be hospitalized. Now coming on to rare etiological agents of pneumonia. Fungal pneumonia. Fungal pneumonia is uncommon but occurs more commonly in individuals with weakened immune system due to HIV, AIDS, immunosuppressive drugs, etc. It is most often caused by Pneumocystis cerevisiae, causes Pneumocystis pneumonia or PCP due to Aspergillus. Fungal agents causing systematic mycosis include Histoplasma capsulatum, Blastomyces dermatitis, Coccidioides immitis, and Paracoccidioides brasiliensis. Travel history gives an important clue about the disease. Histoplasmosis is common in the Mississippi River Basin and coccidiomycosis is common in the southwestern USA. Here, bacterial agents causing pneumonia. Bacterial agents that rarely cause pneumonia include Burkholderia pseudomyeli causes melioidosis, Coxiella burnetii causes Q fever, Chlamydophila pistachii patients give history of exposure to birds, Chlamydia trachomatis serotype DK causes infant pneumonia, Actinomyces and Nocardia, Bacillus anthracis causes pulmonary anthrax or wool sorters disease, and Yersinia pestis causes pneumonic plague. Now, the parasitic lung disease agents that affect the lungs include Paragnomius westermanni causes endemic hematopsis, Ascaris lumbricoides causes Loeffler's pneumonia, filarial nematode cause hypersensitivity in lungs called topical pulmonary eosinophilia TPE, parasites that infect elsewhere rarely infect lungs such as Entammobacter litica, Cryptosporidium and Echinococcus, etc. Now coming on to tuberculosis, TB is one of the greatest killer of mankind and infectious disease caused by acid-fast bacterium Mycobacterium tuberculosis. It spreads from an infected person by aerosol transmission. Although 1/4 of the world's population has been infected, most infections lead to latent tuberculosis, that is, they do not develop to disease and are not capable of transmission. About 5 to 15% of the latent infection, especially who are immunocompromised, progress to active disease, which, if left untreated, kills about half of those infected. Every year, about 100 lakh cases of TB occur worldwide with nearly 15 lakh deaths. TB generally affects the lungs, pulmonary TB, but can also affect other parts of the body, extrapulmonary TB. The classical symptoms of active pulmonary TB are chronic cough with blood containing mucus, fever, night sweats, and weight loss, which lasts for months. Early diagnosis and institution of appropriate antitubercular therapy is the key to successful outcome. Lung abscess. Lung abscesses represent necrosis and cavitation of the lung following microbial infection. It usually presents as a single cavity of more than 2 cm size. Etiology. Lung abscess can present in two forms, primary or secondary. Primary lung abscess accounts for 80% of the cases, generally results from aspiration mainly caused by anaerobic bacteria or microaerophilic streptococci present in the oral cavity. It usually occurs in the absence of an underlying pulmonary or systemic condition. Secondary lung abscess arises in the setting of an underlying condition such as a bronchial foreign body or tumor or immunocompromised condition such as HIV. Common organisms implicated are Staph aureus, gram-negative rods, example Pseudomonas, Enterobacteriaceae, Nocardia, Legionella, and fungi such as Aspergillus, Mucorales, Cryptococcus, and Pneumocystis jirovecii. Clinical manifestation initially lung abscess present similar to that of pneumonia with fever, productive cough, and chest pain. In anaerobic etiology, progression is slow and indolent with features of night sweats, fatigue, and occasional foul smelling sputum in case of putrid lung abscess. In case with non-anaerobic etiology such as Staph aureus, the course is more fulminant with rapid progression. Treatment of lung abscess. In primary lung abscess, clindamycin is the first line treatment antibiotic of choice. In secondary lung abscess, antibiotic coverage should be pathogen directed based on culture susceptibility report. A pathogen prolonged course is often required until resolution of the abscess. Pleural effusion and empyema. Pleural effusion refers to the presence of excess quantity of fluid in the pleural space, an area which lies between the lung and the chest wall. There are various causes of pleural effusion: infection, malignancy, heart failure, cirrhosis, and pulmonary embolism, etc. Our discussion will be limited to infection related to pleural effusions, which may occur secondary to bacterial pneumonia, tuberculosis, or viral infection. Parapneumonic pleural effusion. It occurs secondary to bacterial pneumonia, more common, lung abscess or bronchiectasis. When pleural effusion becomes grossly purulent, it's called empyema. Patients present with an acute febrile illness consisting of chest pain, sputum production, and dull note observed on percussion. Presence of excess pleural fluid can be demonstrated with radiograph or CT scan. If free fluid separates the lung from the chest wall by more than 10 mm, a therapeutic thoracensis drainage of pleural effusion should be performed. Tuberculosis pleuritis, it usually occurs in primary TB and primarily due to the hypersensitivity reaction to tuberculous proteins in the pleural space. Patient present with fever, weight loss, dyspnea, and or pleuritic chest pain. Elevated TB markers in the pleural fluid such as adenosine deaminase or interferon. Viral pleural effusion. Pleural effusion secondary to viral infection is less common, usually gets undiagnosed. These effusions resolve spontaneously with no long-term residua. Now coming on to lab diagnosis of LRTI. Specimen collection. Important specimen for LRTI includes sputum, induced sputum, tracheal aspirate, bronchoalveolar lavage, protected specimen brush (PSB), lung aspirate collected by transtracheal aspiration, and pleural fluid collected by thoracensis. Microscopy. Gram staining of the sputum or other specimen is done for two purposes. Sputum quality. If pus cells are more than 25 and epithelial cells less than 10 per low power field, such samples are regarded as good quality sputum when the chance of recovery of the pathogen is more. Presumptive identification. Gram stain gives a preliminary clue about the etiological agent based on the morphology. For example, gram positive cocci pair lanceolate shaped suggestive of pneumococcus. Pleomorphic gram-negative Coccobacilli suggestive of Haemophilus influenzae. Acid-fast staining of the sputum by ZN technique is performed to demonstrate the acid-fast bacilli, example Mycobacterium tuberculosis. GMS stain Gomori methamine silver stain is used to demonstrate Pneumocystis cerevisiae. Culture specimen should be collected before antibiotic therapy for better yield of organisms. Sputum culture is a standard culture method for pneumonia. Only the good quality sputum specimens, as revealed by gram stain, should be subjected to culture. Specimens are inoculated onto blood agar, chocolate agar, and McConkey agar and incubated overnight. The yield of positive culture from sputum samples is variable. Blood culture may also be performed in addition, especially in hospitalized patients, although its yield is low, 5 to 14% of cap. For lung abscesses, when a primary lung abscess is suspected or lung aspirate is subjected for anaerobic culture, sputum is not a suitable specimen for anaerobic culture. However, for secondary lung abscess, sputum or blood cultures can be performed. For M. tuberculosis, specimen should be inoculated onto LJ medium or automated MGIT microbacteria growth indicated tube culture. For fungal pathogen isolation, saberurad dextrose agar is used. Serology. Antibody detection test can be used for diagnosis of atypical pneumonia pathogens such as Mycoplasma, Chlamydia, Coxiella, Burnetii, and viruses. A fourfold rise in specific IgM antibody titer between acute and convalescent phase serum samples is generally considered diagnostic. They are less popular in recent days because of the time required to obtain a final result of the convalescent phase sample. The various antibody detection methods available are Mycoplasma co-agglutination test and ELISA formats are available. The chlamydial antibodies microimmunofluorescence test can be performed. Q fever, Coxiella burnetii indirect immunofluorescence assay IFA is available. Viral infections antibody detection methods are available for influenza or COVID-19. However, antibodies usually appear late, therefore not of much use in clinical diagnosis, although useful for estimating seroprevalence. Antigen detection test. Various antigen detection methods available for lower respiratory tract pathogens include immunochromatographic test. ICT is available for detection of pneumococcal antigens in urine. Enzyme immunoassays available to detect L. pneumophila serogroup 1 specific soluble antigens in urine. Direct fluorescent antibody tests are available for influenza virus and respiratory syncytial virus and Bordetella pertussis but are poorly sensitive and technically challenging. Molecular methods are emerging as the most promising tool for diagnosis of LRTI. Multiplex PCR assays are available where multiple primers targeting the genes specific for common suspected agents of LRTI are used. Biofire film arrays and automated multiplex PCR commercially available. Its pneumonia panel can be simultaneously detect 33 pneumonia pathogens, including both bacterial and viral agents, from sputum or BAL specimen with a turnaround time of 1 hour. For common bacterial pathogens, which are usually the colonizers in the respiratory tract, it gives semi-quantitative results, genome copies per ml, therefore helps in differentiating colonization and disease. Real-time PCR is the gold standard diagnostic method for detection of agents of viral pneumonia such as influenza and SARS-CoV-2. Automated real-time PCR such as GeneXpert and TrueNAT can be used for identification of Mycobacterium tuberculosis in sputum. In addition, it also detects rifampicin resistance. Okay, so this completes our introduction to the unit. An essay on 16-month-old boy admitted with fever, lethargy, productive cough and pleural sputum, shortness of breath, examination, dull note on percussion and consultation or auscultation were noted. Sputum and blood specimen were obtained and for bacteriological culture. This is the case of lobar pneumonia, can add the clinical diagnosis, radiological agents and pathogenesis. Short notes on acute laryngotracheobronchitis, crowd, Vincent, angina, pleural effusion also we can write. Okay, so this completes our chapter. Next we'll be starting with pneumonia. Like, share, subscribe. Thanks for watching.